Thin girl.
Hi, can you hear me? Okay, good. Good morning. My name is Dr. Rahul Kapur. I'm not going to ask, like my predecessor, whether the in-person or the picture is nicer. The picture is much nicer. Thank you very much to my past speaker, Dr. Nofal, to talking about Axios and what they do and the definition of care. I kind of wish I had gone before you because I think your talk here is very interesting, especially in context of what I'm about to talk about. Why is this a problem? Right? Why do? Is it working? Okay. Let's talk about global health spending. Right? Global health spending in 2020. This is data from the WHO. What you see before you is a graphic showing the impact and the amount of spending done by countries across the world. USA contributes 43.5% of all global health spending.
Very nice to see you after a long time.
All of it. Alright? If you look at kind of the developed economies in yellow, they make up roughly 2/3 of all global health spending, right? And that's probably 20 countries. You've got China, Brazil, Russia, India down here. Lower middle income and low income countries make up only 4.2% of all global health spending. Less than 5%. And they have over 50% of the world's population. So when we talk about access to care, this is the problem. Okay. So when you look at the disparity across health spending, so one problem is, hey, you've got developed countries which make up over 2/3 of all spending. But where is the spending coming from? When you look at the world again, spread out, what you can see is health spending per capita. US is over $2,000 per patient. Germany is over $2,000 per capita, not even per patient, sorry. And on the other hand, you've got Sudan at less than $50 per capita. What's interesting though is, in lower middle income and low income countries, more of this spending is out of pocket. It's not government paying for it, it's patients paying for it themselves. So not only are you spending less, but you're spending it out of your own money. Right? No one's paying for your cancer care there. When you look at the proportion of health spends, you can see in purple on the left inpatient care, you can see outpatient care in orange, and you can see medical goods, that includes pharmaceuticals, in green. What's interesting is while inpatient care, the proportion of spending differs across these countries, in green it's roughly the same. It's 18 to 20%, wherever you are in the world. And what you just heard is if you're in a lower income country, you are spending that out of pocket. And it's a smaller proportion. Right? So, you aren't seeing a lot of spend in preventive care, you aren't seeing enough spend perhaps in other care, but you are seeing equivalent amounts of spend in pharmaceuticals and inpatient care. Now this is why I wish our talks were reversed in order, because the access story would have been over a lot harder after we'd seen this, yeah? Can we go to the next slide, please? Thank you. When you look at the growing burden of non-communicable diseases, now this is especially important for non-communicable diseases. When we talk about oncology, when we talk about diabetes, these are all non-communicable diseases, right? On the right-hand side, you can see a world map. Anything that is red, the proportion is higher. Anything that is closer to white, proportion is lower. You can see across the world, you are differing proportions of non-communicable diseases. Right? What's important to note is that they cause over 70% of all global deaths. But 77% of all non-communicable deaths are in low and middle income countries. So, the thing that causes the most deaths globally, most of it is in low and middle income countries. And these are not diseases which go away. These are non-communicable chronic diseases. You're spending lifelong on it. If you're a diabetic, you need your injection every day with insulin. If you're a cancer patient, you need chemotherapy, you need immune modulated care, you need CAR T therapy if you're very, very lucky and you can get that, and that doesn't go away very quickly. The WHO projects that by 2030, NCDs will cost the global economy over $47 trillion. Now, even Elon doesn't have that kind of money. Biologics are the most advanced form of therapies we have. Now you've got differing types of biologics. You've got, everything from monoclonal insulins and monoclonal antibodies, which we're very used to CAR T therapy, to now precision-based medicine, where you are developing a drug for a single patient. They account for almost 40% of total drug spending, especially in oncology and diabetes. The annual average cost of biologics per patient is in excess of $100,000 in some cancers. So, that's why I'm going to talk to you a little bit about biosimilars and the impact they have on economies. Next slide. So, why a biosimilar? What is a biosimilar? A biosimilar is basically a follow-on biologic. It is a me-too biologic created once patent expires. What you are hoping to do with them is to remove some of the challenges with biologic therapy. We talked a little bit about the impact of biologic therapy and how these therapies are reserved for last in line. Right? It's not for the patients who are sort of diagnosed. We talked about early access to therapy. And this is what we are hoping that bringing biosimilars into health economies does. You allow for earlier intervention. You allow for enhanced patient accessibility. I was dreading a little bit to talk about access here, but hey, we've talked about access. I don't have to do that, so thank you. You can hopefully foster innovation and enhance R&D capabilities. And most importantly, you reduce the cost for drug development and therefore the cost that patients pay. I want to start with the European adoption landscape, not for anything else, but let's be honest, Europe, you get the best patient level data. Right? You've got large scale databases, easier to mine for the data. Europe's also been the earliest adopter of biosimilars. EMA, the European Medicines Agency, had biosimilars come into the market about 10, 12 years ago, so they've really been ahead of the ball there. You have 5.8 billion patient treatment days. The biosimilars since 2006, right? What you have seen since 2006 to 2023 is 50 billion euros in cumulative savings, with 10 billion in 2023 alone. As the rate of change increases, you're starting to see those savings accrue more and more. What you also start seeing is that in the UK, for example, 25,000 more patients with moderate rheumatoid arthritis got access to biological treatment. What that meant is, in the old days, if you were saying you had moderate RA, you didn't get biologics. You got steroids, you got all the non-biological disease-modifying agents. You had to say you have severe rheumatoid arthritis before you got adalimumab or etanercept or whatever it was. Okay? So as you bring in lower cost biologics, you bring more patients into that treatment pattern. By 2028, the assumption is the biosimilars impact will be over 50% of the patent competition in Europe. However, even in Europe, only 14% of the volume of medication sold for these diseases are biosimilars. So you're basically at the tip of the iceberg, right? And Europe is the global leader. They've got over 50% of global biosimilar use. So Europe's only got 14%. let's figure out where we are in Southeast Asia. Yeah, it'll be much less. All right. This is, it looks complicated. I'm going to walk you through it. All right, it's not that scary. What this is, and again, this is European data. What we did is we tried to break down the biosimilar versus reference use by country. Now, we did some complicated mathematics on this side where we looked at the Herfindahl-Hirschman index. Let's not get into that. But basically, if you have more biosimilars, you tend towards the green. If you have only one product available for a therapy, you tend towards the red. And you can see in Europe it's pretty healthy. Usually 50% you have multiple therapies for a product. Why is that important? It brings costs down. The more options you have, the better for the patient. If we looked at insulin, for instance, this would look very red with little green. And if we looked in immunology, again, a very different picture. Can we go to the next slide, please? So we then broke this down further. And what we said is, if you look at what the lost savings were. So if in a market, 90% of patients were not on biosimilars, then you see like a 5% reduction. If 70% of patients, and that's the top blue line, the bottom gray line, were on biosimilars, the lost savings are small. If you look at 30%, then you can see sometimes you might have for where you're spending $1 billion for a product, you might see lost savings of up to 300 million that you could have potentially saved. Now, why does this matter to health economies? Well, if you move on, please. It's the opportunity cost. What can you do with that money that you are saving? Can you bring more patients to biological therapy earlier in the pathway? Could you have additional staff? Can you build more infrastructure? Can you go later to more cutting-edge innovations and further medications, right? So there is an opportunity cost for every decision you make in a health economy. This is an area that I'm learning. My background, as you heard, I'm a medical doctor, I've done research, I've done the fun science stuff, right? And that's very interesting. If you really want to make a difference to a lot of people, then this is where you kind of start. There are barriers to biosimilar adoption and access. I'm not going to go into the whole health treatment pathway. We talked about access, we talked about what we do, and yes, to reform these systems, you probably have to include the restaurant next door to the hospital as well. I'm choosing to focus on one part, right? You have weak regulatory frameworks. You've got different kind of frameworks across low and middle income countries. These are starting to get homogenized, but we're still not there yet. Inappropriate labeling of drugs as biosimilars. You have a biosimilar is a complex biological molecule that is produced by a biologic mechanism, and it is following on. It has the same structure, the same molecular structure, shape, size, and is produced by a molecular method. You have other products which are called biosimilars but are not. They're what are called biocopies, usually generic products. So inappropriate labeling doesn't help because that reduces confidence in what you do. Quite often there's a dependence on importation. These are complex molecules to make. It is not as easy as producing a paracetamol. So you are dependent on importation, you are dependent on supply chains across multinational. Low awareness of biosimilars. What is a biosimilar? Why are you changing my insulin? I've had those conversations with patients. I've been using insulin for 10 years. This is not the same box. Why have you changed my insulin? Right? So there is a massive educational aspect to it. There's an educational aspect from the healthcare professionals. Before I started looking at this, I would have asked, why are you changing my patient's insulin? I'm used to this green, you've given me a different green color, I don't like it. It is not as good. I don't know what's in there, but it's a different green color, I don't like it. It's a different package. And then a lack of effective policies. If you don't mandate quite often, then people are creatures of habits, doctors included. We tend to go what we do where we know and what we do and what we've done for years. So, sorry, if you can go back. So, what do you do in this scenario? Well, one part of it is you try and bring out more evidence, right? So there is some data that we've been working on across, go to the next slide please, the last few years. We've seen that biosimilars, this is data from India, where we talked about HER2 negative cancers at the start, if you remember. Here we're talking about HER2 positive. And seeing the biosimilars do actually improve access for patients with HER2 therapy. What we saw is that usage increased sometimes 17 times. Patients treated with biosimilars grew 230%. And it did have an actual impact on healthcare expenditure. This is India where a lot of this is out of pocket. So the fact that you had a more affordable option and more patients could move on. We've seen similar data in Asian patients, and this is one of the questions I keep getting asked, right? Okay, you've got a follow-on Me Too. How do I know it's as good? There is a lot of data out there. It's worth looking at that data. There's real-world data, in this case biosimilar trastuzumab. In Asian patients, we looked at it across geographies, Europe, US, North Africa, Asia, and there's a lot of data out there. And as these fields start becoming more and more understood, we talked about 5.8 billion patient base, 1 million, billion. Start understanding the efficacy and safety of these products. There are issues. I mean, I painted a very nice picture. I said, hey, I talked to you about a problem, I gave you a solution, and I said, we're all done, right? But there are issues. It's not that easy. We're coming up to what we call the biosimilar development void. When you look on the right-hand side of the screen, what you can see is as biologics expire date. For non-orphan drugs, there are only 12%, and this is US data, where there is a biosimilar in pipelines. Over 88% of biologic products do not have a biosimilar in pipeline. For the most expensive drugs, they aren't going to be cheaper options unless we start doing something for it. Right? You can go to the next slide. So what are we doing about it? There's a lot of global effort underway. Right? You start looking at data across EMA, FDA, a lot of the regulatory agencies to streamline the development pathways. Biologics are complex to develop, complex to license, complex to make. And that adds to biosimilar costs as well. So anything you can do to reduce that complexity helps make it better. So there is conversations going on right now with multiple global regulatory agencies on what is needed to approve a follow-on biologic. With improvements in functional assays, with improvements in biomarkers, with improvements in how we understand proteins, the need for what assays are needed and what is needed to approve these products has become more streamlined. Right? So, in conclusion, I got told 5 minutes, so I'm completely on time. I've got 1 minute left. All right, I can take my time on this slide. In conclusion, there is vast inequality in global health spending. That is definitely not surprising to anyone in this room. Right? Health spendings by governments at LMIC is at a fraction, and a small fraction, of spending in the more developed economies. Out-of-pocket spending makes up a significant proportion. The impact of NCDs on health and health mortality is much higher in these countries due to socio-economic conditions. We talked a little bit about oncology patients having to spend the night in hospital corridors to get access to drugs. Right? So it is leading to a perfect storm. Biosimilars can help in making complex medications more accessible. However, there are significant barriers which need to be worked on. Uneven uptake and usage means that sometimes in the countries that need it most, patients don't have access. Changes to regulatory pathways which may impact timelines are making the situation better, and hopefully globally as we homogenize, it makes it simpler and easier to use. And of course, education and advocacy can impact this in a positive direction. So thank you very much. I think we're going to take questions together, so I'm just going to do that. Thank you.